live streaming is on. All right, for those just joining us, evening. Today is what now, 19th October 2020, and we are continuing with our CVS discussion, right? Okay. So we're going to be showing questions on the screen, and we're going to be answering the questions for PLAB-1 exam. We've already treated anatomy in previous live streams before, and we're currently in cardiovascular system, and we hope to continue that way and proceed down the topics here: cardiovascular system, CNS, dermatology, emergency, endo, ENT, just that way till we get to the very end, miscellaneous, right? So, and our target is to complete this in 2 months' time. Okay, so we spent about a week now on this. So, first question here. Dr. Chara, do you think we've treated this question before? This question is: a 40-year-old woman admitted with pyrexia, arthropathy, breathlessness, syncope was recently diagnosed with pulmonary emboli. There is an early diastolic sound and a mid diastolic rumble. Yes, we have. We have. Okay. Okay, we have. A 44-year-old woman has lost weight over 12 months. She has also noticed episodes where her heart beats rapidly and strongly. She has a regular pulse rate of 90 beats per minute. Her ECG shows sinus rhythm. What is the most appropriate investigation to be done? Yeah, shows TFT. Said that one. But 5-year-old lady has 10 months history of shortness of breath. She is found to have irregular pulse. I mean, let's start from here and then proceed downwards. So, a 45-year-old lady has 10 months history of shortness of breath. She is found to have irregular pulse and loud P2 with fixed splitting and ejection systolic murmur in the left second intercostal space. What is the most probable diagnosis? We did this anyway, but just for Noya. You're welcome, Dr. Noya. You've been missing in action for quite some time now. All right, so attempt the question. I'm sure Tara knows the answer already, but you attempt the question. All right, here's the. And what gave it away was loud P2 with. All right, so I even went on to explain these different types of splitting, from physiological to wide splitting to splitting. So fixed splitting and even reverse splitting. Fixed splitting is kind of pathognomic for ASD, right? Atrial septal defect is known to be a splitter, right? Then also mentioned ejection systolic murmur, and we know that aortic and pulmonary and aortic stenosis are ejection systolic murmurs, okay, in the left second intercostal space. So anything that is related to the pulmonary, when there is an atrial septal defect, there's likely going to be affectation of either the aortic or the pulmonary outflow channel. So in this case, there's affection of pulmonary outflow channel. And then irregular rhythm, that's pulse, tells us that it makes a diagnosis of atrial fibrillation. When there's atrial fibrillation, it implies that pathology is in the atrium, so which is partly what suggests the atrial septal defect. It's not tetralogy of Fallot. It's not tetralogy of Fallot. Okay. All right. See, my screen is not showing. You guys are not seeing my screen. Let me see. The staples, let me try to solve that. Is it showing now, Dr. Chara? Is my screen showing now? All right. Guess I have to try something else. Please stay. Okay, guys, I'm back. So I believe my screen will show in 1, 2, 3, go. Is it showing now? I want to believe it's showing now. All right. Yeah. All right. So we'll go to the next question. So the next question is about a 45-year-old man who had recently started taking antihypertensive therapy. 6 months later, his random blood sugar is 14 millimoles per liter. Which single drug is most likely to have caused this? All right. Is it amlodipine, benzoyl-flumethiazide, doxazocin, losartan, ramipril? This one is straightforward. Just asking about the side effects of the drug. All right, good. Is thiazide. One of the side effects of thiazide, hyperglycemia and insulin resistance, right? Yes, then it also causes it's called like hyperglycemia, hyperuricemia, okay, hypercholesterolemia, right? Apart from the hyponatremia, hypokalemia, hypochloremia, all the hypos, the electrolytes, right? But in terms of glycemia, is hyperglycemia, hypercholesterolemia, hyperuricemia, okay? So whether it is 6 months or 6 minutes, the answer is the same. Like this question now, change 6 months to 6 minutes, right? The same principle. Okay, so hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. So it seems calcium is um, the only electrolyte that is high. Others are normally low. Then it's also known to cause impotence, right? Right. So unlike amlodipine, you have gingival hypertrophy, edema, non-responsive to diuretics. So amlodipine itself, calcium channel blocker, can cause edema, leg edema, ankle edema, headaches, then left ventricular function, decreased left ventricular function. That's why amlodipine or calcium channel blockers are generally not used because they themselves can even trigger leg swelling, right? And even decrease the left ventricular function. Okay, so calcium channel blockers are not, they've been found to have no effect on morbidity and mortality. So if for anything, based on this side effect, we wouldn't propose that it wasn't the outcome for heart failure patients, right? So, but you can use AC inhibitors like ramipril. You know, the side effects of AC inhibitors is with the code captopril. So there's this dry brassy cough, right? Angioedema, proteinuria, hyperkalemia, some other things, even renal failure too. Captopril. Just look at it. Let me look for it. Okay. So captopril pneumonic can be used to remember the side effects of AC inhibitors. So it includes cough, angioedema, potassium changes, that's hyperkalemia, taste changes, all right. Then hypotension, that's the O, is hypotension. Then pregnancy changes can be teratogenic, so it's avoided in pregnant women. You know that, right? AC inhibitors, ARBs, they can cause renal dysgenesis or renal agenesis, right? So you don't use them in pregnant women. Then rashes, because then increased renin or renal disturbances, then causes hyperkalemia as well. So just remember these ones. This taste change, I think, is something you can add to the list of the things you remember. Okay, so that's that about, and that's what differentiates AC inhibitors from ARBs, that's angiotensin receptor blockers, because ARBs do not cause dry cough. So when you are treating a patient and the patient was not having cough before, started ramipril, patient starts having this dry, brassy cough. Mimics our recent coronavirus, all right? So you want to change that AC inhibitor to ARB, right? So a 45-year-old man who is diabetic and hypertensive but poorly compliant, has chronic shortness of breath, develops severe shortness of breath and chest pain. Pain is sharp, increased by breathing, and relieved by sitting forward. What is the single most appropriate disease diagnosis? Diabetic, hypertensive, not compliant with not compliant with his medications, and he developed shortness of breath, which worsened, and there's chest pain. Pain is sharp. This is the clincher. You know, for PLAB-1 exam, you have to look for the clincher. This is the clincher now. Pain is sharp, increased by breathing. So it is a diuretic chest pain, right? Diuretic chest pain. So what do you think is the source of that pain? And it's relieved by sitting forward, right? So what's the diagnosis? Is it lung cancer? Is it myocardial infarction? Is it pericarditis? Is it good pasture syndrome? Progressive massive fibrosis? Drop your answer, guys. It is pericarditis. Okay, you can see that pericarditis is associated with the pleura. Okay, pericardium is associated with the pleura because they all have similar embryonic origin. Okay, they are all related to that same central tendon. Okay, so anything that affects one will affect the other. So when the chest is moving on inspiration, the chest expands, the diaphragm flattens, right? So all those things are going to pull on the heart. Remember, the heart is sitting on the central tendon, which is closely related. In fact, pericardium is the parietal pericardium is strongly attached to that central tendon. So pulls, if the diaphragm flattens, it will pull on it. And remember that pain of parietal pericardium or parietal pleura will be a referred pain. So you now feel the pain on the chest. Okay, it's unlike the pain of myocardial infarction, whereby the pain is crushing. This one is sharp, but that one is crushing. Crushing, it is tightening, and it's localized to the left side of the chest, radiates to the neck, to the jaw, to even the tip of the shoulder and the left arm. All right. So these are things you have to have at the back of your mind. Then pain of myocardial infarction is worsened by exertion, and if it's a stable angina, it will be relieved by rest. But if it's an unstable angina, it will be worsened. It will just keep getting worse, whether you are resting or you are exerting. All right. So the same thing with myocardial infarction, it just gets worse. Okay. Then meanwhile, the pain of pericarditis is relieved by sitting forward and worsened by breathing in. That's the inspiration. That's why it's called a pleuritic pain. So it's sharp or stabbing behind the sternum or in the left side of the chest. However, some people with acute pericarditis, it's very dull chest pain. Okay, so move. 45-year-old manual worker presented with 2-hour history of chest pain radiating to his left arm, which means a myocardial infarction. His ECG is normal. What is the single most appropriate investigation? So there was a question I asked you guys one time like that. I think I posted it in the group. Then I gave answers. So there and then you realize that someone just having a chest pain, like of cardiac origin, aside pericarditis, it could be stable angina, it could be unstable angina, it could be a myocardial infarction, where you're talking about an acute coronary syndrome. All right. So it could be ST segment elevation, myocardial infarction, or ST segment like non-ST segment elevation myocardial infarction, even cardiac syndrome X, right? These are all differentials, and it's from investigations that you'll be able to tell the differences. For example, now you have ECG here is normal, so it is not an STEMI, all right? It's not an ST segment because it's normal. Then, so it's either a non-STEMI. So what will now help you to determine further if there is actually an injury to the heart is cardiac enzymes. And the most sensitive, the ones that will give you the best answer, all right, is the cardiac troponins I and T, all right? So, guys, give me your answer. I don't think you've answered. Cardiac, I've already given you the answer, Seth. Cardiac enzymes. So if a 6-year-old Afro-Caribbean man is found to have a BP of 160/90 on 3 separate occasions, what is the best initial treatment? When you have a patient that has blood pressure elevated more than 140/90, more than or equal to 140/90 on 2 or more occasions, at least 4 hours apart, That's the definition of systemic hypertension, right? So now they painted a picture for you. So this is an Afro-Caribbean man. So this is the clincher. This is the clincher, right? So an Afro-Caribbean man. What do you do? What will be your first line? Well, the clincher is both the age and the race. So for 6-year-old man that is Afro-Caribbean of origin, all right, with systemic hypertension, what will you start? Which drug will you start first? Yes, it's calcium channel blockers. For patients elderly patients more than 55-year-old, right? You start calcium channel blockers regardless of age, regardless of race, all right? But for younger patients, that patient less than 55-year-olds, all right? Ideally, you should have started them on ACE inhibitors or ARBs. But patients that are of Afro-Caribbean origin, then calcium channel blocker has been found to be best first line, right? And they are the ones that have this APO1 gene affectation. So you guys came across it in your primaries, national. Yeah. So APO1 gene enzyme. But this is the one I said I would change. I need to reflect it. All right. Come again with the explanation. It's just nice guidelines on hypertension. That's what I'm telling you. It has 4 steps. It has 4 steps. All right. The step one, the first step. Now, first of all, divides individuals into age. Right. Everybody above 55 years old is treated with calcium channel blockers. All right, regardless of race. But anyone that is below 55 years old, if the person is of Afro-Caribbean origin, you want to use calcium channel blockers as your first line. But if not of Afro-Caribbean origin, you're going to the UK, you're going to meet a lot of whites. You want to use ACE inhibitors or ARBs for them, right? If they are younger than 55, but not of Afro-Caribbean origin. But if the person is of Afro-Caribbean origin, then you should use CCPs. All right. Then the second line, that second stage now, when you've used that first line and using it alone, because you start with monotherapy before you enter dietherapy, before you enter triple therapy, okay? And like that. So you don't just jump straight, start giving a patient multi-therapy, all right? So the first one is monotherapy. Then the second stage, when that is still not controlling the hypertension, you now want to include second drug, which is generally an ACE inhibitor, ARB. That's assuming you've already started CCPs as a first line. Okay, then the third line, you now want to include diuretics, thiazide, diuretics, all that. So in Nigeria, we generally use this brand name Moduretic. It contains hydrochlorothiazide and amiloride. Okay, so that's why you see generally here that patients are normally giving calcium channel blockers, maybe amlodipine 10 milligram. Then you see them taking lisinopril or ramipril. Then you see an additional moduretic. Many patients are on that triple therapy like that. Okay. Then eventually the fourth line now, you now want to include spironolactone, but your choice, preference for spironolactone will depend on whether the patient's on the patient's potassium level. Right, all right. So if you have a potassium level above 4.0, right, you should not start spironolactone. But if the potassium level is below 4.0, you can start spironolactone. It's already has a normal potassium. So you know that spironolactone is a potassium sparing diuretic, so it's going to increase potassium level. Okay, then the final line, that's where you now use other drugs like doxazosin, that's alpha-1 blockers and all that. Okay. I'm not really seeing the guideline. Let me see. And I'm giving you is ESPA stuff, specialist stuff. Then, okay, that's good. If you are going to the UK, you should learn it. This one is blurry. I don't know why. All right. Just try and manage. You can see the age. Make this thing better. Okay. I think it's better here. So you can see the age less than 55 years or with type 2 diabetes. Okay. You go to step A, and A is ACE inhibitor or ARB. Okay. Then for people that are above 55 years or Black patients of African Caribbean descent, you go to CCBs. It's something I explained, but I'm just showing you diagrammatically. Then step 2, you add A plus C or A plus D, okay, where D is thiazide and C is calcium channel blocker. So if what you started before was A, you add C or you add D, okay. Then step 2, on this side, you add C plus A, C plus D, okay. Then step 3 is A plus C plus D. That's 3 medications now, all right. Then step 4, confirm resistant hypertension with ankle bronchial pulse, whatever, pulse monitoring. Okay. Sorry, arterial BP monitoring or home BP monitoring, ambulatory BP monitoring or home-based BP monitoring, and assess for postural hypotension. Consider seeking specialist advice. Then you can now add low dose spironolactone. You know the dose of spironolactone now. So is it that you give 50 milligram, 25 milligram, 12.5 milligram? But they're talking about low dose. So where you use like 12.5 milligram, where you use like 25 for heart failure patients. Okay. So low dose spironolactone, if blood potassium is less than or equal to 4.5 millimole per liter. Okay. Then alpha blocker or beta blocker if blood potassium is more than 4.5 millimole per liter. So if BP remains uncontrolled, we refer to a specialist. Remember what you are going to UK to do. You are basically practicing as a general practitioner. Okay. So that is that for that. I believe I'm understood, right? Okay. 6-year-old African Caribbean man is found. Okay, the same question. Answer this one before, Dr. Shara. Remember? Okay. If a 6-year-old man with tachycardia has the following ECG, what is the most likely diagnosis? So let's zoom into the ECG and look at the lead 2. Okay. So let's look at this very well. Can you identify a P wave? I think I can. P wave. There's a P wave here. There's a P wave here. And the delta wave. Delta wave is a slurring, like R prime. So instead of this R wave, just go straight bar. Now you are having this slurring, this break here, angle here. okay, before it now continues going up. That's what you call a slurring. That's what you call the delta wave. So P wave, and you can see the PR interval is very short. There's almost no space. Normally, there's supposed to be some space. Maybe P wave is supposed to be somewhere here, all right? And there will be some space. No, PR interval is supposed to be like 3 to 5 small boxes. That's like 0.12 to 0.20 seconds, right? So, but here there's almost no space. In fact, you can't even specify any space. So there's a short PR interval. There's that slurring. Also here, slurring. Okay. So it's a we are dealing with Wolff-Parkinson-White syndrome, right? So it's not atrial fibrillation because you can see that the waves are regular. The interval between the R waves are very regular, right? There's no irregular rhythm, and P waves are not absent. The fact that P waves are present shows you that it's not atrial fibrillation. Then Mobitz heart block, Mobitz type 1, right? The PR interval is supposed to be long, prolonged PR interval. That's what tells you it's AV nodal block. Because Mobitz type 1 is a type of AV nodal block. Okay? So means the PR interval is supposed to be prolonged. Depending on the rates. Because now I'm not able to calculate the rate because I can't see the boxes very well. Okay, so before you say supraventricular tachycardia, there has to be you have to be able to calculate the rate first and be sure that there is a tachycardia. So when there is now a tachycardia, you now want to tell what type of tachycardia. Is it sinus tachycardia? Sinus tachycardia, there's a P wave, there's a disparable P wave, discernible P wave. Okay? Then you want to know whether there is a supraventricular tachycardia, in which case you cannot find any identifiable P wave. Maybe the P wave is hidden within the QRS complex or even coming after QRS. Then in ventricular tachycardia, okay, that one is a whole different pattern because there will be widened QRS complex telling you that it's of ventricular origin. Whereas in supraventricular tachycardia, it's called a narrow complex tachycardia, right? So even assuming there is no delta wave, doesn't necessarily straightforward just tell you that the answer is supraventricular tachycardia. First of all, you have to determine that there's a tachycardia. Then second of all, you have to determine that there is no discernible P wave before you say it's SVT. Okay. So I believe I answered your question, Cornelia. So, because this old woman has weight gain, sensitivity to cold, bradycardia with a pulse of 50 beats per minute, the heart is enlarged with murmur. What is the single most likely diagnosis? Hypothyroidism, hyperthyroidism, Cushing syndrome, Addison's disease, leukocytoma. We should analyze each of these options one by one and see possible symptoms and signs we come up with. Sarah, you stay here? Oh, okay, or you're just keeping the questions that we've treated before. It's just Noya that is dragging us back. Next time I'll flog him, give him digital flogging. We just be receiving flogging from his village people. He will not know he's flogging him. All right. So obviously there's cold intolerance. Okay, so that tells you, in fact, that alone self already tells you it's likely hypothyroidism. If it's hyperthyroidism, you'll be expecting a heat intolerance, right? Then you'll be expecting a tachycardia. But in hypothyroidism, you are seeing a bradycardia. Okay, so they also have cardiac enlargement. Both hypo and hyperthyroidism can cause cardiac enlargement, and high output heart failure, and murmurs can be found in hyperthyroidism. All right. So that's not it. And then see this is the at the clinicals, right? And also, of course, weight gain too. Weight gain is very important because in hypothyroidism, that's where you see weight gain. Unlike in hyperthyroidism, what you see is weight loss, right? Very important to identify and differentiate. Then Cushing syndrome. Cushing syndrome is patient where you have the hyperadrenal corticolism, right? Okay, hypercortisol. So elevated cortisol level, which could be primary or secondary. So if it's primary, it's that's the one they call Cushing's disease, right? Whereby the adrenal gland is just secreting cortisol, but because it's being stimulated by the pituitary gland, and cortisol for cortisol to be released, there has to be in fact it's a process from the hypothalamus to the anterior pituitary gland, then down to the adrenal cortex, right? Which particular part of the adrenal cortex secretes cortisol? Which zona what? Is it zona glomerulosa? Is it zona fasciculata or zona reticulata? Okay. I had a code then, GFR equal to MGA. So glucocorticoids are released by zona fasciculata. Okay, you are correct, Dr. Moya. So Cushing syndrome, there's now an excessive secretion of which hormone is secreted from the anterior pituitary that stimulates the zona fasciculata to release cortisol. Yes. All right. Adrenocorticotropic hormone. Meanwhile, adrenocorticotropic hormone is also receiving stimulus from the hypothalamus from which hormone? All right. Yeah. Also releasing hormone, right? Corticotropin releasing hormone. ACTH is also called corticotropin. So CRH is corticotropin releasing hormone. So releasing hormones come from hypothalamus, stimulate the anterior pituitary gland to release ACTH, right? And we know that the pathway for the production of ACTH is related to pro-opiomelanocortin pathway, right? So the same pathway that releases ACTH is also involved in production of melanin, right? Pro-opio, even opioids too, opioid receptor. So pro-opiomelanocortin receptor, POMC, right? So that's why anything that affects that pathway is going to cause person to start having this pigmentation, hyperpigmentations, and excessive opioid stimulation. All right, so that's Cushing's syndrome for you. So this one I'm even talking about is the primary Cushing's syndrome, which is Cushing's disease. And the secondary one is when you now have external steroids being pumped into the system. So external steroids, right? That's what happens when people take steroids for a long time, start gaining weight. All the side effects of steroids, very many multi-systemic side effects of steroids from the neurological system. There's even steroid psychosis, right? Steroid-induced dementia, a lot of things. Cardiovascular system, it itself is a risk factor. When you talk about the proper weight gain and all the features, follow on, moon face, egg on stick, all those things, all right? They are all features of steroid. Even the skin, dermatological, you have striae, skin start forming striae, thinning of the skin, poor wound healing, and steroid has anti-inflammatory, antipyretic, analgesic effects, and all those things. But all the side effects are exaggerated features of the mechanisms of action of steroids. All right, so that's Cushing syndrome. And Addison's disease is primary primary hypoadrenalism, right? So all the things that are involved means the adrenal gland is not secreting enough, okay, and it's primary, which means sometimes it can be congenital, right? Then pheochromocytoma is not talking about the adrenal cortex, it's talking about the adrenal medulla, because when you're talking about pheochromocytoma, you're talking about synthetic hormones, right? As adrenaline and noradrenaline. So you now have excessive release of adrenaline and noradrenaline because of overgrowth of adrenal medulla tissues. So it's a tumor. So tumor that overproduces adrenaline and noradrenaline and all the attendant effects of adrenaline and noradrenaline. And one thing it presents as is systemic hypertension. This kind of resistant systemic hypertension that no other thing can treat. You know? So before you do the surgery, eventually the person will have to undergo surgery where you are even removing the adrenal gland, right? Before you do the surgery, you have to use what do you call this? A combination of beta blockers and alpha-1 adrenergic blockers, phentolamine, phenolphibenzamine, okay? These are the only things you can use. In fact, I think it's one of the questions you'll meet in pharmacology. So it's there. Take a look at Addison's disease again. Yeah, adrenal insufficiency, a common disorder that occurs when your body doesn't produce enough of certain hormones. Okay. Yeah, primary adrenal insufficiency and hypocorticolism. Hypoadrenalism, primary adrenal insufficiency, chronic adrenal insufficiency. Okay, so you can see darkening of the skin. So it's the clinical features that made me open this. Comes abdominal pain, weakness, weight loss, darkening of the skin. Complications, adrenal crisis. All right. They even have low blood pressure. Just the way you should remember the features is because you're going to have is a hypoadrenalism, all right? Because you're going to have both the zona glomerulata, zona fasciculata, zona reticulata. So even the adrenal hormones, as the sex hormones, are going to be involved. Testosterone, all right, going to be affected. Mineralocorticoids are going to be affected. And we know that mineralocorticoids are involved in blood pressure maintenance, okay, and body fluid maintenance, all right? So there will be hypovolemia, hypotension, in the reverse, you now have a hyperkalemia, all right? Then the for the cortisol itself and all the effects that cortisol is supposed to have in the body. Now start having low energy, generalized body weakness, all right, weight loss. Okay, so vomiting and lower back pain. Those ones are related to the level. Then loss of consciousness, poor immunity, of course. Expect that to be poor immunity. The person is prone to sepsis, infections, and all that. Pigmentation. Darkening of the gums due to increased pigment as seen in Addison's disease. Look at the gums, very dark. Wow. So, the reason is because the POMC, remember that thing I told you before about POMC? So when POMC is, the level of POMC is is normal, okay? But the things that are supposed to be produced from pump C are not available. So MSH will now be overstimulated because MSH is also produced from pump C. So melanocyte stimulating hormone will now be overacting because it's now too abundant because the other pathway is pathway that produces cortisol and co are not being activated, right? So eventually, that's why the person will have hyperpigmentation. Look at this one, at the back, it's very dark. Okay. So Addison's disease is associated with development of other autoimmune diseases. So it's actually an autoimmune disease, such as type 1 DM, thyroid, that's Hashimoto's thyroiditis, celiac disease. Celiac disease is an autoimmune disease of small intestine, right? Affecting the brush borders. So the person is no longer able to absorb. The person now has chronic diarrhea, abdominal distension, malabsorption, loss of appetite, inability to grow. Hyperthyroidism, or both is called autoimmune polyendocrine syndrome type 1. Okay, the presence of Addison's disease in addition to autoimmune thyroid disease, type 1 DM, or both is called autoimmune polyendocrine syndrome type 2. I think it's probably important to take note of APS, APS type 1, APS type 2. So APS type 1 is Addison's disease with mucocutaneous candidiasis, hypoparathyroidism. Okay, why APS type 2 is Addison's disease with autoimmune thyroid disease, which is motothyroiditis or Graves' disease, and type 1 DM. Okay, so I'm just gonna now the adrenal crisis itself. Let me quickly talk about that. That one is like when all these symptoms that we mentioned, when they get worse. So in a situation where there is sudden onset of worsening of symptoms that are supposed to arise from adrenal disease, adrenal hypo. All right. So, for example, you now start having sudden penetrating pain in the legs, lower back, abdomen, severe vomiting and diarrhea resulting in dehydration, low blood pressure, in fact, turning into shock, right? Syncope, loss of consciousness, inability to stand, hypoglycemia. Of course, we know that cortisol is involved in synthesis of that's gluconeogenesis and even intake. In fact, it's a catabolic hormone, so you're meant to it's meant to release glucose into the blood. So when cortisol is not available, you start having hypoglycemia, right? Confusion, psychosis, swordfish, lethargy, hyponatremia. Remember, I told you about hyponatremia. Remember, its relationship to the catecholamines and its relationship to the mineralocorticoid hormones. So when there's low mineralocorticoid hormones, including aldosterone, right, there will be hyponatremia, but there will be hyperkalemia because there's one-on-one exchange of sodium and potassium in the kidneys, right? And hypercalcemia, elevated calcium in the blood, convulsions, fever. Okay. So let's just look at the hypothalamus stimulates, releases corticotropin releasing hormone, which stimulates the pituitary gland to release ACTH, which is corticotropin, right? Which finally stimulates the adrenal cortex to release corticoids, which is what we've been saying. And the glucagon now puts up a negative feedback on both the hypothalamus and the pituitary gland. So, for 7-year-old man with history of ischemic heart disease, complaints of chest pain with shortness of breath on exertion over the past few days, ECG normal, echo decreased ejection fraction, and decreased septal wall thickness. What is the most likely diagnosis? This one is a middle-aged man, history of ischemic heart disease, right? Which means part of the heart is probably dead, infarcted. Okay. So now he's having a chest pain, shortness of breath on exertion. So what I think the patient has is acute decompression of chronic heart failure, secondary to DCM. Yeah. The options here. So if this patient came to me, what I would have managed is heart failure, right? But DCM will be the culprit. ECG is normal, so there's no. But echo has decreased ejection fraction, right? And decreased septal wall thickness. We have dilated cardiomyopathy. In dilated cardiomyopathy, ejection fraction is decreased with decreased septal wall thickness. Because that's why it is dilated. When there's ventricular dilatation, septal wall thickness will be decreased. The next question is about a 48-year-old man who has continuous anterior chest pain, which is worse on inspiration, and has temperature of 37.5 since 4 weeks after an MI. His ESR is 45 millimeter per hour. What's the single most likely explanation? No, you're asking a question. That ECG can be normal in someone with heart failure. Why not? It can be normal. Of course, it can be normal. When the cause of this thing is not rhythm changes, ECG only picks rhythm changes, right? Yeah, apart from rates, there are so many other things that ECG picks. Rates, rhythm, hypertrophy, all the hypertrophies, whether atrial, ventricular, right atrium, right ventricle, left atrium, left ventricle, all those things. The axis deviation. There's so many diagnoses you can make from ECG, but it's not all of them. Not all of them you can make from it, right? So ECG can be normal, but that's why they told you that 2D echo is showing you something. That's why when you're investigating a patient for heart failure, you do chest X-ray. You start with chest X-ray, then you go on to do an ECG, then you go on to do a 2D echo, right? So all these are important because if the other one is normal, the other one may be abnormal. Okay. So for you to say a patient has heart failure, it means something must be wrong in that 2D echo. Right? That's where you make your diagnosis of heart failure. That's apart from the chest X-ray that's going to show likely a cardiomegaly. All right. But 2D echo will show you the functions of the heart and the heart valves and the ventricular wall thickness and ejection fraction. All right. So when a patient has either elevated ejection fraction, that's high output, or reduced ejection fraction, that's low output. Most patients that we have here have hypertensive heart disease. Okay, so because of the heart failure, it's usually hypertensive heart disease. But in younger patients, we tend to see dilated cardiomyopathy. And dilated cardiomyopathy is related to a lot of things, including HIV, including diabetes. A lot of things can cause dilated cardiomyopathy. Even alcoholic heart disease cause dilated cardiomyopathy. So back to the question at hand. We mentioned a continuous anterior chest pain. Continuous, keyword continuous. Was on inspiration, which means it's also pleuritic. Then temperature is normal. Okay. And he had an MI. So yes, it's the post-myocardial infarction pericarditis, which is known as Dressler syndrome. That's what the patient has. And duration also tells you, because I think Dressler syndrome occurs 2 to 6 weeks after a myocardial infarction. So if it's earlier than that, then so it's not acute. Dressler syndrome usually occurs 2 to 5 weeks, not 2 to 6 after initial event, but it can be delayed for as long as 3 months. It's characterized by periodic chest pain, low-grade fever, and pericarditis. So they consider the temperature of 37.5 as low-grade fever. So that's if you use your cutoff as 7.2. 48-year-old, it is a different question. 48-year-old presents with severe chest pain since the last 40 minutes. In the emergency department, he is given oxygen, glycerin, trinitrate, morphine. ECG shows ST segment elevation. So it's an STMI, right? Blood, that's investigation, shows increased troponin levels. So it's still an STMI. What is the next step of management? Will you give beta blockers? Will you do percutaneous angiography? Do anticoagulant and heparin, clopidogrel, aspirin? Funia, what do you think? Do you think we should knock the patient aspirin a bit? No, the patient will actually need. Anyway, so aspirin, next line, because you've already made your diagnosis, right? Where you are going to rush and do a percutaneous coronary angiography is when, let's say, the ST segment elevation is absent, and then there's still increased troponin levels. Remember, once you do an ECG, ECG is the first thing you do when you're suspecting an MI, right? ECG is the first thing you do, and followed by your bloods, right? That's your blood investigations for cardiac enzyme markers, all right? And for troponin, the common ones, troponins, I and T. So, all right. So after that, you now want to do an angiography. So if by chance the ECG was normal, suggesting it is a non-STMI and troponins are increased, all right, which also suggests it's a non-STMI, then you now want to do a percutaneous coronary intervention, angiography. I will now tell you whether these things are actually affected. So, but in this situation, you want to quickly give aspirin, and in this case, what you give is 300 milligrams of aspirin, okay? 300 milligrams start, then 150 milligram daily. That's what you give instead of the regular 75, because aspirin is one of the things that will help these patients to have a good outcome. It's an platelet, and will help to prevent platelet aggregation, platelets formation, and all that around coronary arteries, which is basically what is going to obstruct the vessel and end up leading to an infarction. Okay, so we are kind of trying to hope that you can revascularize or reopen all those vessels. Yes, now aspirin is vasopressin. Vasopressin is a trade name. Antiplatelet. That's why you use it in a prevent stroke. But this is 75 milligram. A 48-year-old presents with severe chest pain in the last 40 minutes. This is the question we just answered. Already, and you know what you do for STMI? You give oxygen, high flow oxygen, right? especially when you check the SpO2 and the SpO2 is less than 95%. You want to give high flow. Okay. Then you want to give morphine. Morphine is an analgesic. Okay, and is meant to prevent or reduce pain. And part of the symptoms that they have, like all these excessive sweating, palpitations, all of them are related. Some of them are related to the pain, symptoms of sympathetic discharge. All right. So when you reduce the pain, you also help sympathetic discharge. There's a place for beta blockers too. The place for beta blocker. Then glycerin trinitrate will cause vasodilation, right? You have glycerin mononitrate, glycerin trinitrate, isosobide dinitrate. All of them are nitrates, right? They all cause vasodilatation through the nitric oxide pathway, right? That's how they act. Cause increased release of nitric oxide and eventually cause vasodilatation. So the coronary blood vessels, essentially increasing blood flow to the cardiac myocytes, right? So oxygen therapy, GTN, morphine, beta blockers, aspirin. In fact, when the patient is just coming in, aspirin should be the first thing you will even do. Maybe you start oxygen. Why you are looking for aspirin? So aspirin 300 milligram starts. That's what you give. Subsequently 150 milligram daily. Unlike normal patient where you just give 75. Another place where you give this high dose aspirin is in a patient that had ischemic CVA. Right? When a patient has an ischemic stroke and is confirmed with CT scan, what you should do is to give aspirin 300 milligram starts, 150 milligram daily. So percutaneous coronary intervention or angiography is the most definitive treatment, but may not always be available. It should be done within 2 hours for maximum benefits. Okay. So always note their keywords. They ask the next step in management. Or if they had asked you what is the most definitive management, all right, you know what to choose. Having PCI. A 4-year-old girl is found to have bounding pulse and continuous machinery murmur. What is the most probable diagnosis? What they use are very specific. Bounding. Bounding pulse suggests high outputs. Then continuous murmur, which is machinery in nature, can only be one thing. It's not VSD. It's not ventricular septal defect. Ventricular septal defect. Oh, you've been missing my class. Cardio is very important. Ventricular septal defect is pansystolic murmur. It's a pansystolic murmur. In fact, I even explained to Dr. Chara how it is different from what's the other one? Tricuspid regurgitation, right? Ventricular septal defect and tricuspid regurgitation both cause a pansystolic murmur, but and they're even both located on that same place where you hear the sound is the same place. So the only thing that will help you to differentiate it is a sign known as the Cavallo sign. All right. So when you tell a patient to inspire, you're listening at the moment to the murmur. So when the murmur gets worse on inspiration, that gets louder on inspiration, you know it is likely a tricuspid regurgitation. But if inspiration and expiration does not affect it, you know it's likely a ventricular septal defect. They are both localized on that same place, the fourth intercostal space on the left. Okay, so parasternal border. So it's a murmur of PDA. That's the only murmur that is continuous and machinery. It's classical. No other thing. Pattern ductus arteriosus. Yes. And that stands for logic, right? What's ductus arteriosus? Ductus arteriosus is actually the vessel that connects the aorta to what now? To the pulmonary vein. And that ductus arteriosus is supposed to be embryonic, right? It's supposed to degenerate as soon as the child is born. It's supposed to close up and all that. But if it doesn't close up, that's why it's now called a patent This patent are called the patent ductus arteriosus. So the flow is going to be continuous, but with each heartbeat, right, there's going to be flow both into the aorta and into the the pulmonary artery. All right. So that communication between the pulmonary artery and the aorta, that's called the ductus. Yeah, yeah. So you can see this is the pulmonary trunk running to right and left pulmonary arteries. Then this is the arc of the aorta. Yes. So arc of the aorta coming down like this. So you now see a communication between the aorta and the pulmonary trunk, pulmonary artery. So this is the ductus arteriosus. It's supposed to degenerate after childbirth, right? And it's the same ductus arteriosus that is influenced by, like for example, when you give a woman, a pregnant woman, NSAIDs, this is the vessel you are going to keep open because NSAIDs, simple prostaglandins are supposed to help. What do they even do again? How do you even put it? Prostaglandins are supposed to help to close up this channel. I think when you now give one NSAIDs in the third trimester, you're going to keep this channel patent. Okay, we move. A 50-year-old female had swelling in her ankles. She is a known alcoholic. Now she presented with breathlessness and palpitations. What is the most likely cause of her condition? Ankle swelling, that's ankle edema. She's a known alcoholic. She's having difficulty in breathing, palpitation. What's the most likely cause of her condition? What do you think? Is it ventricular tachycardia? Is it supraventricular tachycardia? Atrial flutter, atrial fibrillation, ventricular ectopics, breathing palpitations, and codes. This patient is in failure, right? This patient is in failure, but it's going to be precipitated by something. What they are looking for now is precipitant. Give me answer, guys. Remember the risk factor is chronic alcoholism. If I was to be the one seeing this, I will make it area of chronic of acute decompression of um, acute de novo heart failure, right? Secondary to alcoholic dilated cardiomyopathy, precipitated by something, likely atrial fibrillation, likely. So atrial fibrillation. Alcoholic cardiomyopathy. Alcoholism is also a no, well-known cause of atrial fibrillation. So we move. A 50-year-old lady presents to the emergency department with sudden chest pain radiating to both shoulder and accompanying shortness of breath. Exam revealed cold peripheries and paraparesis. What is the single most appropriate diagnosis? 50-year-old lady, sudden severe chest pain radiating to both the shoulder and both shoulder, all right? And there's associated shortness of breath and cold peripheries, paraparesis. Is there an MI? Is there an aortic dissection? Is it pulmonary embolism? good pasture syndrome, motor neuron disease. Remember, there is a paraparesis. And there is a pulselessness, relative pulselessness, perishingly cold. Remember all those 7 Ps? Perishingly cold, pulselessness, all those things. No, it's not an MI. Sudden severe chest pain, radiating to both shoulders. Are you not seeing the other associated symptoms? There's cold peripheries. MI will give you cold peripheries. Well, MI can give you cold peripheries. I know because of maybe cardiogenic shock, not paraparesis. The paraparesis there. So it's not an MI. The answer is very obvious. It's not an MI. It's aortic dissection. It's aortic dissection. Because of that paraparesis. This is the clincher here. So everything they are mentioning here can happen in other things. Now, this one is relating to the shoulder, but something else that suggests is that this one is related to both shoulders. Normally, an MI pain relates to the left side, right? Left arm, left shoulder, the neck, on that side, the jaw. Okay. So, and then it's crushing. This one is going to be a tearing pain. That's the feature of aortic dissection pain. It's tearing. Tearing. It feels like something is tearing. It's tearing pain. And it's related with the shock. Because remember, aortic dissection is like you're breaking a vessel into two and you are pouring blood in between the vessel, in between the intima of the vessel. All right. So you are losing blood, but it's internal. When it's going to go into shock, that will explain the cold peripheries. You can also have hypergenic shock in myocardial infarction. But when you have paraparesis, it's telling you that the arc of the aorta, the aorta is not getting enough supply. So paraparesis. And you know that nevorum, no, vasonevorum. So as vessels that supply the nerves also come from the aorta, right? So and you know the nerves down from the lumbar plexus down, everything there be affected. That's why you're having paraparesis. So it's aortic dissection until proven otherwise. So aortic dissection, cold peripheries due to reduced blood flow, distal part of dissection, and reduced perfusion of nerves resulted in paraparesis. Usual management for type A dissection is surgery, and for type B is conservative. So let's look at the types of aortic dissection. Because type A, I think it has type A, B, and C. Okay. Type A is the one that stops at the at the arc of it. In fact, there are two different types of classifications, depending on the one you want to use. Get chest or back pain. Tearing pain. Can even give abdominal pain too. Vomiting, lightheadedness, stroke. And it's strongly related to all this Marfan syndrome, connective tissue disorders, Turner syndrome, bicuspid aortic valve, major trauma, smoking, hypertension. Okay. Looking for the types. Pathophysiology, blood penetrates the intima and enters into the medial layer. have a wide aortic nerve on chest X-ray. Wide aortic nerve. Instead of the normal unfolding of the aortic of the aorta, which you see in systemic hypertension, this one is a wide nerve. Suggests dissection. Looking for the type. So classification of aortic dissection. There's the Bakke classification and there's Stanford. Okay. So in the Bakke has type 1, type 2, type 3. Stanford has Stanford A and Stanford B. I think the explanation in the question is talking about Stanford classification. So Stanford classification is just proximal. That's before from the arc of the aorta down as proximal dissection, right? Then Stanford type B is distal. So from the arc of the aorta down to the aortic, abdominal aorta, and all that. Thoracic, abdominal aorta, all those ones are Stanford type B. Okay, that's distal. Then the Bakke type 1 and the Bakke type 2 are proximal. All right. So that's essentially what you need to know about that. And because Bakke type 1, because Stanford type A is proximal, you have to do a surgery. But for type B, there are so many organs you're going to come across. For example, if someone has an abdominal aortic aneurysm, and before you can get to that aorta, and once you touch it, things are going to go very wrong. So that's when you want to do a conservative approach, right? I hope it makes sense now. So an old man came to the hospital a few months ago after he had an MI. All right. On examination, everything was normal. S1 and S2 were ahead on auscultation, but there's a new pansystolic murmur. What's the most appropriate investigation of choice? Came to the hospital a few months ago after he had an myocardial infarction. Everything normal on exam. S1 and S2 were ahead on auscultation. No murmurs. Okay, but there's a new pansystolic murmur following an MI that happened months ago. What's the most appropriate investigation of choice? The only thing that will tell you about murmurs very well is an echo, right? I already told you that the reading is normal, the things are normal, so you're not ECG you're rushing to. There's a new pansystolic murmur. And when we talk about pansystolic murmur, it could be ventricular septal defect or tricuspid regurgitation. So for someone that has an MI, anything can happen. Yes. Valvular lesion following papillary muscle rupture, septal lesion, which is ventricular septal defect. So next one is about a 50-year-old man who has a stab wound to his left anterior chest at the level of the fourth intercostal space. By the way, when someone has a stab wound to it, I don't think you should be in a hurry to go and pull out the object. Especially the penetrating injury. Don't be in a hurry, except you're already in the theater setting, right? But if you pull out that object, that means the coagulation around that object may be what is keeping that patient alive. Pull it out, the patient will just bleed out. That's all. So if 50-year-old man has a stab wound to his left anterior chest at the level of the fourth intercostal space, he has a BP of 80, and is in shock, pulse of 130 beats per minute. His neck veins are dilated and his heart sounds are faint. Trachea is central. We've answered this question before. patient is likely in shock, stand bone to the intrapericardial pressure, right? Thereby compressing the heart and preventing the heart from expanding during ventricular relaxation. So the heart can no longer dilate appropriately to accept. So there will be very little venous return. And that backflow of venous return will show up in the neck as elevated because there will be reduced intraventricular and systolic volume, and diastolic volume, and all that. There will be backflow of blood. All right. There will also be increased intra-atrial pressure, and you know that the tubular venous pulsation measures the right atrial pressure. So you'll now be distended neck veins, all that. Okay. So, drop in blood pressure, increase in pulse, tachycardia, tension. Patient is at risk. And what also gave it away is the faint heart sound. So normally the heart sounds in cardiac tamponade or constrictive pericarditis are said to be faint at distance. That's the word they use. Distant heart sounds. That tells you it's likely cardiac tamponade. So how do you differentiate cardiac tamponade from constrictive pericarditis? One is that cardiac tamponade, of course, is a sudden onset, right? Constrictive pericarditis can be chronic, right? Takes time to occur. And usually the heart has adapted to it. Okay? Unlike in cardiac tamponade, where the heart hasn't adapted because it's sudden onset, so the heart cannot be able to adapt very quickly like that. So now begin to have all these changes. And the trachea being central tells you it's not from the chest. So it's not a tension pneumothorax, it's a very close differential. It's not a hematothorax, right? Hemothorax, fractured ribs. And the differences between cardiac tamponade, constrictive pericarditis. Let's see whether I will find something nice to watch.
I have to stop and tell you guys.
Hello, friends. So there are some signs. I want us to take it once and for all.
What happens in cardiac tamponade? In cardiac tamponade, there is impairing of the chamber.
Okay, I'm going to put up the video in the in the room so that it will be more, to be bolder.
So what happens in cardiac tamponade? In cardiac tamponade, there is impaired filling of the chambers because fluid accumulates in the pericardial cavity. How is the ECG in cardiac tamponade? It has a low voltage ECG in limb leads. What are the other conditions that produce low voltage ECG? Three conditions that produce low voltage ECG are constrictive pericarditis, restrictive cardiomyopathy, and cardiac tamponade. And what else you see in a ECG in cardiac tamponade? In a cardiac tamponade, we see alternating QRS size due to a swinging heart. This is a low voltage EKG, and this is the alternating QRS complexes in cardiac tamponade. So what are the clinical features of the cardiac tamponade? Muffled heart sounds, pulses, paradoxes, pericardial effusion, equal pressure in all the four chambers and low amplitude QRS complexes and electrical alternance of the QRS. So there is equal pressure in all the four chambers and low amplitude QRS complexes and electrical alternance of the QRS complexes. So what's a low voltage EKG? A low voltage EKG is when a QRS complex is less than 5 millimeters in limb leads and less than 10 millimeters in chest leads. And what are the non-cardiac causes of low voltage EKG? Obesity, COPD, severe hypothyroidism, massive myocardial infarction or damage, and infiltrative disorders. How about the X-ray chest in the cardiac tamponade? It produces increased size in the cardiac cells. This is the fluid around the heart on X-ray chest. And what do you see in X-ray chest in constrictive pericarditis, which has a low voltage ECG also? We have a rim of calcification around the heart, and this is usually seen in chronic condition as in tubercular pericarditis. What are the other causes of constrictive pericarditis? It may also be caused by uremia and SLE. And what you see in an echocardiography in constrictive pericarditis. The pericardium is thickened in constrictive pericarditis, and there is a dilated inferior vena cava in constrictive pericarditis. How is the diagnosis of cardiac tamponade made? Echocardiogram confirms the diagnosis, and the treatment is pericardiocentesis. Right ventricular infarction may resemble cardiac tamponade. Third condition that produces the low voltage ECG is the restrictive cardiomyopathy. So what is restrictive cardiomyopathy? This is the condition where the walls are rigid and is stiff, but the rhythmicity and contractility of the heart may be normal. What are the conditions that cause restrictive cardiomyopathy? They are sarcoidosis, which is treated with steroids, amyloid, hemochromatosis, and endocardial fibroelastosis, and Noonan syndrome. There is right heart failure in both constrictive pericarditis and restrictive cardiomyopathy, both of which have low amplitude QRS complexes. How about the EKG in restrictive cardiomyopathy? Apart from low voltage QRS complexes, it has non-specific ST wave abnormalities. Echocardiography, CT, MRI typically reveals symmetrically thick left ventricular walls and normal or slightly reduced ventricular volumes. Atria are usually dilated. Echocardiography shows diastolic dysfunction. Ventricular biopsy is normal in constrictive pericarditis. Right heart failure in both constrictive pericarditis and restrictive cardiomyopathy, both of which have low amplitude QRXs.
You've not been hearing what the video was saying. I've been playing the video now. You're not hearing it. Anyway, summary of the events. So that Let me look for a simple image. Okay, so can you see? I hope you can see me. You can see my screen. Tomoya, you say you can't hear. Can you hear me now? Can you see my screen? All right. So, difference between constriction and tamponade. Tamponade, low cardiac output states. All right. But in constrictive cardiac, both of them have low cardiac output state. Then jugular venous pulsation is present in tamponade, also present in constriction, but there's no Cosmos sign. What's Cosmos sign? There's no Cosmos sign in tamponade. Okay. Then equalize diastolic pressures in both of them. Right atrium, there's blotted Y descent, but in constriction, there's rapid Y descent. So in tamponade, there is absent Y descent. That's when you plot the ACSVY, JVP waveform. All right, there's absent Y descent in tamponade. So those are the basic differences. And there's also decreased heart sounds. But in constriction, there's a pericardial knock, pericardial friction rub, right? That implies a pericarditis, friction rub, pericardial knock. Okay. Then absent Y descent in tamponade. Okay. Then no Cosmos sign. No Cosmos sign in tamponade. There's Cosmos sign in constrictive pericarditis. So ask ourselves, what is Cosmos sign? Cosmos sign has to do with inspiration. Like sometimes a paradoxical rise in jugular venous pressure on inspiration, or a failure in the appropriate fall of the JVP with inspiration can be seen. So normally during inspiration, because of increased intrathoracic pressure, the jugular venous pulsation is supposed to fall. All right. But in Cosmos sign, there's now a paradoxical rise in jugular venous pulsation on inspiration, that's Cosmos sign. And it is absent in cardiac tamponade, but it's present in constrictive pericarditis. Just like Y descent is absent in constrictive pericarditis. So it can be seen in some forms of heart disease, and it's usually indicative of limited right ventricular filling due to right cardiac dysfunction. I think at the end of this, it should be done, right? So the causes: right ventricular infarction, right heart failure, cardiac tumors, constrictive pericarditis, even restrictive cardiomyopathy, also a close differential of this. And so cardiac tamponade, constrictive. Remember that cardiac tamponade has no Y descent and has no Cosmos sign, unlike in constrictive pericarditis that has both Y descent and Cosmos sign. Let's see what the Y descent stands for. Remember the ACXBY waveform. Y descent in it. So Y descent is present in constrictive pericarditis. While it is absent or reduced in So why descent is actually early ventricular filling. It's seen in early diastole. Okay, it implies early diastolic filling. The ways I've been telling you about. A, another one C, then X descent, B, then Y. Okay. All right. I think with that, we've come to the end of today's discussion. You guys are no more responding, so I don't even know if you're hearing me or you're not hearing me. But we'll have to end the discussion here at this point. We stopped at 28%. Just remind me that the previous class was 28%. Thank you for joining up. Thank you for joining up, and see you tomorrow. Bye. Have a good night. Let's try and start on time tomorrow so that to avoid stories that talk. Okay. So for those joining us from YouTube family, thank you also for joining us, and see ya tomorrow. We've streamed for about 1 hour now. We're gonna have to end the stream at points.